If you have knee pain, knee arthritis, one sentence can change your entire lifestyle. You have osteoarthritis, arthritis. For many people, that sentence sounds like a permanent ban on. No walking, no stairs, no squatting, no exercise, no fun. Only sofa, TV remote, and deep philosophical discussions with the knee. And the most common fear is this: Doctor, if I walk with my cartilage, will my cartilage wear out more? The fear is understandable because we have been told for years that arthritis is wear and tear. So naturally, many people imagine the knee is like a tire. More use means more wear. More walking means less cartilage. More stairs means direct booking for knee replacement. But today I want to challenge that idea, not recklessly, not dramatically, but scientifically, because your knee is not a simple machine part. It is important to understand that it is a living biological joint. And for many people with knee arthritis, the problem is not movement itself. The problem is the wrong dose of movement. Too much can irritate the knee, but too little can weaken the whole system also. So today we will discuss a new study on aerobic exercise and knee osteoarthritis. But more importantly, we will discuss a myth. Does exercise damage knee cartilage, or can the right exercise actually help the arthritic knee? In clinic, this is very common. A patient walks in and says, "Doctor, I saw my x-ray, arthritis has started. From that day I stopped walking." I ask why. They say to protect the cartilage. This is where Doraisamy enters our story. Doraisamy is a 54 years old gentleman. He has mild to moderate knee arthritis. The moment he saw the x-ray report, he retired from movement. Not from job, from movement. He told his wife, Meenakshi, "From today I am not climbing stairs, I am preserving my cartilage." Meenakshi asked, "Then who will go upstairs and bring your phone charger?" Doraisamy said, "That is why marriage exists." Meenakshi looked at him and said, "Your cartilage may be preserved, but your marriage will not be preserved." This is the first lesson. In every house, there is usually one practical person who brings us back from medical overthinking to real life. Complete rest sounds safe, but long-term rest has consequences. The knee becomes stiff, the muscles become weak, weight increases, confidence decreases, and pain sensitivity can increase. And slowly, the patient becomes more afraid of movement than the arthritis itself. One major mistake patients make is this: pain equals damage. That's what many people have in their mind. But in arthritis or osteoarthritis, pain is not always a direct damage meter. Two people can have very similar x-rays. One is walking 5 kilometers and another is struggling to walk inside the house. But why is it? Because pain in the knee osteoarthritis can come from many things. It can come from the joint, inflamed joints, synovium, which is sac around the joints, bone marrow changes, muscle weakness, poor sleep, weight gain, fear of movement, and sometimes increased pain sensitivity and metabolic health. So your x-ray is important, but your x-ray is not your full biography. It is one chapter. It's not the whole book. This is very important because many people stop moving after seeing the x-ray even before the knee actually stops them. The diagnosis creates a fear. The fear creates a rest. The rest creates the weakness. The weakness creates more and more pain. Then the patient says, "See, doctor, arthritis is worsening." But sometimes what is worsening is not just arthritis. It is the inactivity spiral which is worsening. We often think of the knee like a door hinge. If the hinge is old, don't use it. But your knee is not a hardware shop hinge. Your knee is a living organ. The cartilage cells, major or cartilage cells, respond to the load. The synovial fluid that responds to the movement, the muscles respond to training, and bone responds to mechanical stress. Even pain responds to confidence and conditioning. Now remember this: articular cartilage has no direct blood supply. Unlike muscle, It cannot simply receive nutrients through blood vessels running inside it. It depends mainly on the synovial fluid, the juicy joint fluid for nutrition. The movement creates a load and unload cycle, like gently squeezing and releasing the sponge. That helps fluid movement, nutrient exchange, and waste removal. So the knee does not like abuse, but the knee also does not like abandonment, remember. It likes intelligent use of the joint. Load, unload, recover, progress. This is the medicine here. Like all medicines, the dose matters. Now let's bring in Kamala aunty. Every family has one Kamala aunty. She has advice for everything. Knee pain, don't walk. Back pain, sleep on the floor. Neck pain, change the pillows. Diabetes, eat bitter gourd and cancel endocrinologist. Kamala aunty sees Doraisamy walking slowly in the street and she immediately says, Ayyo Doraisamy sir, you have knee arthritis. Don't walk, cartilage will finish. Doraisamy gets scared. He goes home and tells Meenakshi, Kamala aunty said if I walk, cartilage will finish. Meenakshi says, Kamala aunty also said her son will stop playing mobile games after 10th standard. Did that happen? This is the point. Advice can sound confident and still be wrong. The modern understanding of knee osteoarthritis, or otherwise it is called arthritis, is not simply wear and tear. It is more complex. It involves mechanical load, yes, but also inflammation, muscle weakness, metabolic health, body weight, sleep, and joint biology. So the question is not should I move or rest. The better question is what type of movement, how much, how often, and what intensity is safe for this patient. Now let us come to the study. A 2026 randomized controlled trial studied 120 people with knee arthritis. The participants were aged between 50 and 75 and had the Kellgren-Lawrence grade 2 to 3, and they were divided into 4 groups: low intensity aerobic exercise, moderate intensity aerobic exercise, high intensity aerobic exercise, and a control group. The exercise program lasted for 12 weeks, the 3 supervised sessions per week, and each session included a 10-minute warm-up, 30 minutes of treadmill walking or stationary cycling, and 10 minutes of cool down. The intensity was monitored using heart rate reserve, HRR. The low intensity was 50 to 60% heart rate reserve, moderate intensity was 60 to 70, and high intensity was 70 to 80% of HRR. They used the Polar H10 chest strap monitors to track heart rate during the sessions. The study measured the cartilage metabolism markers, pain, WOMAC score, 6-minute walk test, knee range of motion, and MRI cartilage thickness and volume. This is important. This was not go walk somewhere and come back if you remember. This was very well supervised, measured, structured, and monitored. So the study asked a very practical question. In knee arthritis, does exercise intensity matter? The results showed a dose response pattern. That means higher intensity group generally improved more than the moderate group, and the moderate group improved more than the low intensity group. The high intensity group showed the largest reduction in CTX2 and COMB. These are the markers related to cartilage breakdown and cartilage turnover. CTX reduced by 28.5% and COMB reduced by 22.3% in the high intensity group. Pain improved, VAS pain reduced by 52.5% in high intensity group. WOMAC score improved by 45.3%. The 6-minute walk test also improved. Now, what is the 6-minute walk test? It is a simple functional test. Ask the patient to walk for 6 minutes and measure how far they can go. It tells us something practical, not just what happened in the blood test, not just what happened in the MRI, but whether the patient can actually walk better in real life. In this study, the high intensity group improved their 6-minute walk distance by 71 meters. To put that in perspective, the paper uses 26 meters as a minimal clinically important difference. That means the smallest improvement likely to matter to patients. So this was not just a number on the chart, it suggested a real functional improvement. High intensity group improved 71 meters, which is almost 3 times that 26 meters threshold. MRI also showed increase in cartilage thickness and volume. In the detailed table, the medial cartilage thickness increased by 4.8% and medial cartilage volume increased by 4.2% in the high intensity group over 12 weeks. Now this sounds very exciting. Doraisamy hears this and immediately says, Doctor, high intensity is best. Tomorrow I will run 10 kilometers. Meenakshi says, first run behind the garbage truck and throw the dustbin. Then we will discuss 10 kilometers. This is where we must be careful. The study is interesting, but it does not mean every knee arthritis patient should suddenly start high intensity exercise. This is one trial. It was 12 weeks. It was from one study group. The participant had grade 2 to 3 osteoarthritis. The exercise was supervised, the heart rate was monitored, and the trial was not prospectively registered in clinical trial registry, which the authors themselves acknowledge as limitation. Most importantly, the MRI cartilage changes should be interpreted cautiously. The authors themselves mentioned that the true structural cartilage remodeling usually requires longer time frames, and short-term changes may partly reflect cartilage hydration rather than genuine tissue remodel. So please do not take the wrong message is exercise definitely regrows cartilage in 12 weeks. That is too strong. The correct message is in selected knee arthritis patients, properly supervised, progressively prescribed aerobic exercise, improved function, pain, walking capacity, and cartilage related measures. That is still a very powerful message, but it is a honest message. What is the myth? The myth is if you have knee arthritis, rest is always safer. No, temporary rest may be useful during a flare. If a knee is swollen, hot, very painful, or irritated, you may reduce the load for a short period. But permanent rest is not the treatment. Permanent rest can become a trap. When you stop using the knee, what happens? The muscles weaken, balance reduces, walking confidence drops, the body weight increases, the blood sugar control may worsen, sleep may worsen, and pain may become more disabling. This is why I tell patients, rest is like a plaster used for the right injury, dangerous if you live inside it forever. Doraisamy says, Doctor, I am resting for safety, but his Apple Watch says today's steps 312. Out of that, 200 steps were searching for TV remote only. This is not joint protection, that is whole body deconditioning. So what should patients actually do? Now the practical part, how should someone with knee arthritis exercise? First, choose a movement your knee tolerates. Walking, stationary cycling, swimming, water walking, elliptical, slow treadmill, but choose a movement your knee tolerates. For some people, cycling is better than walking because it gives movement with less impact. For some, walking is fine. For some, strengthening must come first. Second, start where you are, not where Instagram says you should be. If your current capacity is 5 minutes, start with 5 minutes. If it is 10 minutes, start with 10 minutes. If you are already walking 30 minutes comfortably, then intensity can be gradually adjusted. Third, use the 24-hour pain rule. Mild discomfort during exercise can be acceptable, but if pain sharply increases, swelling appears, limping worsens, or pain remains significantly worse the next day, that load was too much. Reduce, modify it, progress more slowly. Fourth, add strength training. Aerobic exercise is useful, but the knee also needs muscle support. Quadriceps, hamstring, glutes, calf, balance. A strong leg protects the knee better than a fearful leg. Fifth, progress gradually. Do not go from sofa to fitness in 1 week. Doraisamy once bought new shoes, smartwatch, sweatband, and protein shaker on Monday, and by Wednesday, only the protein shaker was active. The knee needs progressive loading, not emotional loading. So what about the high intensity? Study suggests higher intensity supervised aerobic exercise may give greater benefits in selected patients. But high intensity is not the starting point for everyone. Think of high intensity as a destination, not the first step. In real life, many patients first need pain control, weight management, the quadriceps muscle strengthening, balance training, proper footwear, sleep improvement, diabetes control, and confidence. For some patients, high intensity may mean brisk walking. For another patient, it may mean cycling at a challenging pace. For another, it may simply mean walking faster than usual for 1 minute, then slowing down. Intensity is very personal. Kamala auntie's high intensity may be climbing 2 stairs, and Doraisamy's high intensity may be walking past a biryani shop without entering it. Both are difficult. Respect both. The point is this. Do not copy someone else's dose. Find your own dose. Build your dose, respect your symptoms, and in real life, physiotherapists and exercise professionals play a very important role in helping patients find the right dose of movement safely. Now, a very important thing. Do not aggressively exercise through warning signs. Please get evaluated if you have severe swelling, locking of the knee giving way, or unexplained severe pain, fever, night pains, and if you have been told by a doctor if you are having some inflammatory arthritis or unstable heart disease, uncontrolled blood pressure, severe breathlessness, or advanced deformity. Exercise is medicine, but medicine needs a prescription. Wrong dose can harm, right dose can really help. When a patient asks me, doctor, should I walk or not? I say, let us prescribe walking like medicine, not randomly prescribing, not emotionally, not because the neighbor said, not because Kamala aunty forwarded one video. We prescribe it, type of exercise, the duration of the exercise, the intensity of it, the frequency of the exercise, how much progression has to be achieved, pain response, and recovery. That is how knee arthritis exercise should be discussed. And remember this line, your knee does not need complete rest. It needs the right relationship with the load. This is the central idea, not too little, not too much, the right dose. So what is the takeaway from this video? This new study should not make us overconfident. It should make us thoughtful. It tells us that many osteoarthritis patients may tolerate more exercise than they think when the exercise is supervised, monitored, progressed properly. It also reminds us that pain reduction and functional improvements are realistic goals. Even if cartilage regrowth is not proven, better movement, better strength, better walking, and less fear are already meaningful outcomes. Because the goal is not just to protect cartilage, the goal is to protect the life. Like walking to a temple, going for shopping, climbing stairs, playing with the grandchildren, traveling, working, living without fear. This is the real treatment target. So, the next time someone tells you you have knee arthritis, so don't move. Pause a little, ask a better question. What movement is safe for me today, and how can I gradually build from here? Because for many people with knee arthritis, movement is not the enemy. The wrong dose is the enemy. Fear is the enemy. Complete inactivity is often the enemy. Your knee is not a glass object. It is a living biological joint. Treat it with respect, give it the right load, give it recovery, give it strength, and give yourself confidence. This is Dr. Naveen Thiyagu. Stay active. See you in the next video. Stay strong and take care of your joints wisely. In disclaimer, this video is for educational purpose only and is not a substitute for personal medical advice, diagnosis or treatment. Knee arthritis varies from person to person. Exercise choice, intensity and progression should be individualized based on pain, swelling, X-ray findings, MRI findings when needed. Body weight, strength, balance, medical conditions and overall fitness. Do not start or increase exercise aggressively if you have severe pain, swelling, locking, giving way, recent injury, fever, night pain, sudden inability to bear weight, inflammatory arthritis, uncontrolled diabetes, uncontrolled blood pressure, unstable heart disease, severe breathlessness, or advanced knee deformity. Please consult your treating orthopedic surgeon, doctor, physiotherapist, or qualified healthcare professional before starting a new exercise program. The study discussed in this video is only a research paper. It showed improvement in pain, function, walking capacity, cartilage-related measures, but it does not prove guaranteed cartilage regrowth. MRI cartilage changes over 12 weeks should be interpreted cautiously because they may partly reflect cartilage hydration rather than true long-term cartilage remodeling. No specific treatment, product, device, or exercise program is being promoted. The goal is education, safe movement, and informed discussion with your healthcare team. See you in the next video. Goodbye.